So good afternoon and welcome to this lunch seminar. And my name is Rosenquist Brandell. I work as a clinical geneticist at Karolinska at Solna, and many associate us with inherited diseases, but we also work with cancer genetics, and in particular we develop tests for leukemia patients, since we know that genetics is very important for patients with leukemia to risk stratify them and to decide which treatment they will have. And today I will present my research focus, which is chronic lymphocytic leukemia, the most common leukemia, and how we use genetics and sort of transfer the knowledge that we gain through genetics into diagnostics, and even first into precision diagnostic, but also into precision medicine. So just a crash course into hematological malignancies. There are three major subtypes. It's leukemias in the bone marrow, that is spread in the leukemic cells are spread in the bone marrow and in the circulation. And then we have myeloma, that is also a bone marrow disease, which derives from plasma cells. And then lymphomas, which is actually a very heterogeneous group of tumor entities. It's actually in the latest classification, it's more than 90 entities that are now defined with lymphomas. And one of them is chronic lymphocytic leukemia. So it is per definition a lymphoma, but also a leukemia. So these patients, they usually have full with leukemic cells in the bone marrow and peripheral blood, but also they have enlarged lymph nodes due to that they both have a, so to say, a nodal disease in the lymph node, but also in the bone marrow. So that was very rapid on the different hematological malignancies. Usually in the statistics they are sort of listed one by one, but if you group all hematological malignancies together, it's around 3,700 that are diagnosed every year in Sweden, out of around 60,000 with cancer. So it's on the top list, 10 most common if you put them together. If we go to diagnostics method, as you know, we have used different type of technologies during the last decade. So cytogenetics is still used a lot, but that was the first sort of global technique. And then we have had new technologies coming in, and lately, the last 5-10 years, next generation sequencing. And when you work with diagnostics for leukemias, we need to look at small mutations, that is single nucleotide variants, or insertions, deletions. It is copy number aberrations, if you have lost a part of a chromosome, or if you have extra material of a gene, and also different type of structural aberrations. I will come back to that. So if I go into chronic lymphocytic leukemia, what is very peculiar with this disease is that even though it's the most common leukemia, 80% are asymptomatic at diagnosis. So they go to the doctor for any type. It could be a health checkup, it could be for any other reasons, and they take a blood test and see that you have increased lymphocytes, lymphocytosis. So the first shock when they meet a doctor is you have a leukemia. And then the next shock for the patients is that yes, you have a leukemia, but since you don't have any symptoms, we will not treat you. And this is something, I understand that this must sound very strange for the patient. I have a leukemia, you say, but you will not give me any treatment. But it has been shown in many studies that there is no, since we do not have a curative treatment of CLL today, it does not help to give treatment at diagnosis. It's no difference in overall survival if you start treatment if the patient is asymptomatic or when the patient gets symptoms. This may change, but right now we wait until the patient gets symptoms. And 1/3 of patients will never develop symptoms. They will live for 10, 20, I think the longest follow-up we have is 40 years without any symptoms and no treatment. They have a leukemia and the body can sort of keep it in control. 15% will get, or 20% will get treatment immediately, and the remaining will develop a need for treatment over the years. The cells are very sort of homogeneous. They are look like a B cell. They derive from B cell, B lymphocytes. So they are small with a small cytoplasm, and this is the nucleus that you see. Despite that the morphology is very similar, I think it's amazing that so far we have discovered more than 2,000 recurrently mutated genes in CLL. And this is partly an explanation why the disease is so heterogeneous, because the genetic landscape is also very heterogeneous. We treat them with two cytostatic drugs, fludarabine and cyclophosphamide, plus rituximab. So that's called immunochemotherapy. But there is a paradigm shift with new targeted therapy, which I will come back to. So what do we do in routine diagnostics? We know that we need to detect a few aberrations that are important for the patient. Let's see, is this the, no. Is there a pointer? Is it in the middle or, yeah. So we need to know a few aberrations. For instance, 17p deletion. Within 17p, the TP53 gene is concluded, and patients that have TP53 aberrations or deletion of 17p, they should not receive standard treatment. They will only relapse, and there is almost no idea to give that treatment to these patients. Then there are other aberrations like deletion of 13q. We know that this patient will probably be among the ones that have a very good survival, and you can sort of, these patients have an expected long lifetime and also probably will not need treatment. And if you should put the normal population, you have to remember that these patients are around 70 years of age when they are diagnosed. And if you look at the survival curve for these patients and put the normal population, it will not be a big difference, the normal death rate with and without CLL. We also need to sequence the whole P53 gene, because patients also with a mutation in P53 have a very, very bad prognosis. And finally, there is a molecule on the B cell, the B cell receptor, that of course defined that it's a B cell, but we know that if the B cell receptor is mutated, the patients have much better survival than if the B cell receptor is unmutated. So this is also something that these tests we have to do before we start therapy. And the B cell receptor, I will come back to it during my talk. It's a central player because, of course, even though I'm a geneticist, the genetics are inside the cells, and then you have the microenvironment that surrounds the cells. And actually the B cell receptor is the communicator outside and inside. So as you know, the B cell receptor responds to antigens and gives signals. So this is an important communicator. And actually, this was reinforced by the new therapies that was approved for high-risk TP53 aberrant patients. There is one BTK, a BTK inhibitor. So we shut down the B cell receptor signaling by this inhibitor. There is another inhibitor to PIK3 that also shuts down the B cell receptor signaling. And these are very effective, very, very effective. And also there is another one, a BCL2 inhibitor, that really can reduce the tumor burden significantly. So for the first time, and especially if we combine two of these, BTK and BCL2 inhibitors, we can reduce the tumor burden so that the patient, so we come to levels that are what we call minimal residual disease, that we have so low levels of disease that we have to use different technologies to measure this low levels. So this, and also if you think that they get chemotherapy and an antibody, but now we're approaching a stage where the patient gets only pills to eat. So it's 2 targeted therapies. Of course, they have side effects, but not the same type of side effects as you have with chemoimmunotherapy. So I think this is a great advancement for these patients. Coming back to this with assays that we need to analyze, or tests that we need to use for these patients, it's important that we measure in the same way. And I have been active in the European CLL group, where we have actually made 2 networks for TP53 and for the immunoglobulin genes, and we have sort of make a certification system. And for me, it's amazing. The interest have been enormous. So it's, as you see, it's 129 certified centers in 27 countries, and almost the same for IgG mutation status. So all these labs have gone through the certification. They have shown that they can analyze this test. Yes, so we have been sort of leading this certification throughout Europe and outside Europe, and it has been a great interest for this. So today we have international guidelines, and that is very important. What should we do for the CLL patients? And this is just to repeat that FISH analysis of these specific cytogenetic aberrations we need to do, and we should always do it for all patients. And what has been added now, 2018, is P53 mutation and IDH mutation status that we always should do for all patients. And then there have been a finding actually from Karolinska and from Huddinge in 1990 by Gunnar Juliusson that the more genomic aberrations you have with chromosome banding analysis, the worse outcome. So we have known this for a long time, but it was reinforced with the new targeted therapies. Ibrutinib, that's a BTK inhibitor, and venetoclax is the BCL2 inhibitor. We see that patients with a complex karyotype, these are the lower curves, they have really poor response to the new targeted therapies. And that has sort of reinforced that we need to detect genomic complexity. And I didn't say that why do we use FISH? That is because it's so difficult to culture chromosomes from CLL patients. Inside the body, they will never die, but as soon as they come out of the body, the CLL cells start dying. So it's very difficult to get them to divide, and you need them to divide if you want to see chromosomes, because you need metaphases. There have come now new technologies that we can sort of culture by giving them interleukins and CpG. We can actually get them to divide. And colleagues from Uppsala have, Panagiotis Baliakas, have coordinated a very large study on 5,000 patients where we have done this new type of cytogenetics. And what we can conclude from this study is that if a patient do not have a TP53 aberration, if the patient have 5 or more genomic aberrations, then it belongs to the group that have a high risk disease with the expected poor survival. If the patient has a TP53 aberration, it starts to matter if they have 3, 4, or 5 aberrations. So it seems that if you have TP53, you can have a fewer number of aberrations and have the worst outcome, whereas if you don't have P53, you need to have 5. The question is then, are there other technologies that you can capture this genomic complexity? And we at our lab in clinical genetics, we use genomic arrays for patients. So we look at genomic aberrations by using a whole genome array. And we also did a European collaborative effort that was recently published, around 2,000 patients. And we could see, similar to cytogenetics, that if you have 5 or more aberration, you belong to this high-risk group. So I think that, and we have actually started a few weeks ago now to notify the clinicians when we see 5 or more aberrations that this is could be in high-risk patients. And you have to consider if you should give them other type of therapy. I think the next step, and I will come back to that, is that because chromosome banding is still takes time and it's still sort of laborious, and also genomic arrays is quite laborious. So whole genome sequencing actually has the potential, the new technology where you can capture the whole genome has the potential to be used to identify patients with genomic complexity. So this is sort of the new toolbox that we have had as researcher, but also as a diagnostic person. It's an amazing revolution of technologies. It has been a technical revolution that we now can analyze the whole genome, 3 billion base pairs, or the exome, or we can fish out the genes of specific interest, and that's what we are doing usually in cancer diagnostic or cancer research, that we cherry pick the genes of interest that we are more interested in. And CLL has been a sort of a paradigmatic disease to look at, to use these new technologies, because since it's easy to take blood samples from the patients, you can really look at the disease at different time points. So what we know now is CLL is always preceded by something called monoclonal B-cell lymphocytosis. That is that you have a clone within your body. 10% above individuals over 60 years have a monoclonal B-cell lymphocytosis. And even though it's 10%, very few of them will sort of transform into CLL. It's expected that 1% per year will turn into a CLL. So we know that it's always preceded by a monoclonal B-cell lymphocytosis. Then patients, as I already alluded to, can have very, very stable disease, but they can also get additional mutations to become aggressive, and sometimes they transform into a high malignant lymphoma that is called Richter lymphoma. So we were wondering, can we use whole genome sequencing to understand what type of genetic aberrations do individuals with a low count MBL, that is, that you have a very small clone within your body, a high count MBL, or ultra stable CLL. So these patients have been followed for more than 10 years, all of them, and they have a stable small clone, or a medium-sized clone, or a larger clone. Actually, these were followed for more than 16 years without any need of therapy. We sequenced them, and we also did ultra-deep sequencing to see that we do not miss any of the known driver mutations. So what did we see? Actually, the genomic landscape was totally indistinguishable between these three different entities. There were around 2 to 2,500 mutations per case, somatic mutations, and there were very, very few driver mutations of the known, let's say, 30, 40 mutations that we know are driver mutations. So what drives the disease then? If we compare to patients with aggressive disease, they have one mutation extra in one of the driver genes. That sort of makes a difference between an aggressive disease and a more indolent disease. And we should not forget, I told you in the beginning that B-cell receptor is very important. So we think that the B-cell receptor is actually one of the major drivers during the disease development. And many of these thousands of mutations are just either by aging, because the clones are in aging people, and probably a lot of them accumulate with age. And then there comes one aberration in one important driver that makes the disease aggressive. This is a fancy paper produced by Kathy Wu's group, where they looked at the clonal dynamics over time, how the cells grow. And what they could see is that either the patient have an exponential growth, intermediate growth, or a very slow growth. That sort of corresponds to aggressive and the indolent disease. And what they saw is that patients with a very slow growth had few aberrations, whereas the ones with exponential has a more aggressive disease. So for me, it's still amazing that just one gene mutation can cause a difference to a more aggressive disease. So these were 2 papers in 2015 showing 1,000 cases that have used whole genome or whole exome sequencing. So what did they show? They gave us some new insights on mutations that are important. Notch1 is activated, so NF-kappa B gets activated. We also have an anti-apoptotic gene called BERK3 that is deleted, also give increased NF-kappa B activation. Then the big surprise were SF3B1, which is a splicing gene that we still don't know exactly how it gives an aggressive disease, but it gives changes in splicing. And many of these genes, I just show you some examples, they have really poor prognosis, Notch1, SF3B1, and BERK3. But the challenge right now is that we have so many hundreds and thousands of mutations that are seen in CLL. So there are only 4 genes that are found in more than 5% of patients. The remaining are sort of below 5, below 1%. And then you can ask the question, are they important or not, the different genes that are mutated, recurrently mutated? And we have shown in a series of papers, yes, they are important, but it makes it a little bit problematic, and it keeps us busy because we have to analyze large patient cohorts. For instance, we looked at EGR2. As you can see, we looked at 2,500 patients, and it's just below 4% of all patients. We looked at different cohorts in Sweden, in the UK, in the US, in China. It's very, very consistent. There are 3 hotspot motifs, and these patients have a very poor survival. TP53 is here, and then on the same sort of level you have EGR2 mutation. And it predicts a poor time to first treatment and also overall survival. And should we include this? Is 4% of patients important or not to identify? And I can show you a number of these type of tail genes that are important. And I think we need to also identify these patients. I will come back to that because now we can do that with the NGS gene panels. Coming to patients with more resistant disease or that relapse on therapy. So which are the drivers and passengers? And this was a beautiful study by Kathy Wu. They combined whole exome sequencing with genomic arrays, and then they could look at the proportion of the tumor that has a certain mutation. And then they could show that actually there are very few clonal mutations. This was MYD88 and trisomy 12. The majority of mutations are subclonal. That is, that they are only found in a proportion of the cells. And that goes well along with that what I said before, that you had, when aggressive disease sort of emerges, you have a subclonal mutation that will increase and cause the sort of aggressiveness of the disease. But actually, to complicate matter, it's not only clonal mutations that are important. For instance, for P53, if you use Sanger sequencing, you would detect, these were 300 patients, around 35 with a mutation, but you have 50 that have smaller clones of P53, which you detect with next generation sequencing. And these patients have similarly poor prognosis as the patients with a large mutation. So even though they have a small clone, this leads to similar poor outcome. So this, I think, is one of the first examples where we need to do ultra-deep sequencing to find these patients, because you should not probably not give them standard therapy. You will only, if you give them standard therapy, these small clones will just grow rapidly, and the patient will get the relapse. So we looked at patients with that relapsed after the previous standard therapy, fludarabine, cyclophosphamide, and rituximab. And we looked at 41 cases, and you start to now to recognize Notch1, P53, etc. These are sort of known genes linked to poor outcome. But then we detected, and this was a surprise for us, a ribosomal gene that was mutated. And in the beginning we had difficulties to believe how could a ribosomal gene be involved. We saw that these mutations were really in an evolutionary conserved area of 7 amino acids. But we asked ourselves, how could this sort of be involved in the CLL pathobiology? We know that it is important for protein translation. I will come back to that soon. So probably it impacts translation. We could show by creating transfectants that actually RPS15 binds to MDM2, and you know that MDM2 regulates P53. So we saw that mutants had an impaired control of, or it reduced P53. So this is another way of reducing P53. But a Spanish group looked into exactly how could these RPS15 mutations impact translation. And to make a long story short, they saw that stop codons and frame shifts were sort of the ribosome allowed them to be read. Usually the ribosome should stop when you have a stop codon or frame shift, but when you have an RPS15 mutation, it seems to allow them to proceed. So the protein has defects when it's produced. We have also looked by ribosome sequencing, and we see that actually these RPS15 mutations sort of lowers the translation. You have a lower efficiency of certain proteins that are less expressed. I will not go into details about this, but we can really see that it affects the translational landscape. These patients, 1/3 of them actually have P50 aberrations, and they also have a very poor outcome. So how to bring this together? These are the mutations that we can see in CLL. It's, as I said, roughly 2,000 mutations. And what we are trying now is to really group them in a good way. This was a recent paper published from a Danish group. They claim that not the number of driver mutations is important, it's the number of pathways that are sort of dysregulated. So if they looked at the number of driver mutations, they defined 25 genes as drivers. They could see, yes, there is some sort of, if you have a higher number of aberrations, you have a worse outcome. But if they looked at number of pathways, they could really start to look at different survival curves depending on the number of driver mutations. We have now sort of collected a large material in order to try to address this. It is almost 5,000 patients that we have sequenced 10 genes, and we are right now currently looking into this. We have just finished the data curation, and these are the number of the genes that are detected and the type of genomic aberrations, and we are just now looking into, does it matter if there are sort of the number of pathways or number of drivers, or the certain genes that are, or mutations that are mutually exclusive. So this will be very exciting, and hopefully can help us to decide which genes we should use in the clinical setting. So finally, this is my view how we should use sort of genetics in CLL diagnostics to help selection of therapy and care for the patients. Today we are using FISH and genomic arrays, P53 and IGH mutation status. What is happening right now is that we are starting to use broader gene panels, and actually in Sweden we have developed one for 250 genes that we will use in diagnostics of lymphoid malignancies. And then you will capture, the first version of it will capture SNVs and copy number, but it's also possible actually to put together also for IGH mutation status and different type of structural aberrations. So it is possible to do a comprehensive test. Instead of doing different tests, you can put them into one test. So this is what I foresee the next coming year. And then I think whole genome sequencing actually has the potential replace a lot of the other technologies. So instead of doing FISH or different NGS, we could replace it by whole genome sequencing. And when you do this, you get small mutations, you get copy number aberrations, and you get structural aberrations. But I think we cannot only do whole genome sequencing, we have to complement it with ultra-deep sequencing. So finally, just to acknowledge a lot of people that have been active in this work, of course here in Stockholm and also in Uppsala where I was before, and a lot of collaborators throughout Europe. So thank you very much for listening.